Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about stroke. Stroke is an extremely common problem, medical problem. Across the world, you have 15 point plus million folks that suffer from strokes. And every year that happens, of that number, 12.7 million of them suffer the stroke because of the hypertension, which is the number one cause of stroke throughout the world. Very, very, very common problem. Every 3.3 minutes in this country, somebody dies of a stroke. Every 53 seconds in this country, somebody suffers a stroke. When I left last week, I was starting to talk a little bit about some of the complications of stroke. Then we'll talk about rehab. Then I'll wrap up the series in this segment after 8 half-hour shows. Now, of course, the symptoms are numerous. The different things that can let a physician or other healthcare professional know, or a family member for that matter, somebody is having a stroke. Usually the person would start stumbling around. They'll lose their ability to stand up. They become weak. Sometimes they cannot speak. They lose their speech, and if they are speaking, they're speaking in a slurred speech. That's one of the ways. The eyes may look bizarre in a different ways, and then they can't walk. They stumble around. The left arm may be weak. The right arm may be weak, and so on and so forth. So, and that may be where the first sign that somebody is having a stroke. The patient is taken to the emergency room. They get evaluated. They do a first thing after you examine the patient. You would get some lab work done, get a chest X-ray, EKG, and then you proceed to get a CAT scan of the brain. After you examine the patient, the CAT scan of the brain will tell you if there is a bleeding, acute bleeding in the brain, and or there's a tumor. That's all you're going to see acutely in the CAT scan. You're not going to see anything more. If there's old stroke, you could see it as well. But if somebody's having an acute ischemic stroke, you're not going to see it in the CAT scan. But you go ahead anyway and do the CAT scan because it's easier to get, and then it will help you to start managing the patient quickly. And if the patient is not bleeding into the brain, you say they're having a stroke, you find out how many hours ago the symptom began, then you could either give the patient aspirin and or TPA to try to block the ability, eliminate the clot, whatever it is that's causing a stroke. That will help the patient save tremendous amount of brain tissue right there and then. And of course, I give a big spiel the last couple of shows about the need not to give too much aspirin. I'm not going to bore you with that again. It is very sad this is happening, but that's what's going on. Sometimes people will give aspirin and Plavix. Why they do that, I have no idea. Because one baby aspirin given to someone for the purpose of preventing a clot from forming or dissolving a clot that has already occurred is sufficient to do the job. That's it, period. One baby aspirin affects the aggregation of the platelet for 7 to 10 days. So there's no more platelet aggregation that needs to be dealt with. Why the Plavix? I have no idea. Why two regular aspirin? I have no idea. But people, of course, they're not hematologists, and most of them are not, and they don't understand platelet physiology. I'm not going to bore you with that again, but that happens to be the fact. In fact, it could cause damage to the patient. The more aspirin you give, the more you increase the possibility of GI bleeding, ulcers, or whatever. The more Plavix you give, the same thing, you increase the incidence of bleeding from occur. Patient is already having a major problem. The last thing they want is a bleeding complication that make matters worse. That's not the intention of the doctors, but that's in fact that can happen as a secondary effect of giving too much anticoagulation to people like that, or too much aspirin, etc. So now that you've got the patient stabilized, you can go ahead and get yourself an MRI, MRA. The MRI will tell you what happened acutely as it related to ischemic activities. The MRA will evaluate the vessel, the vasculature of the brain for you to see there is no aneurysm, there is no stenosis that you could actually see that's blocking the passage of the blood, etc. So you move from there, and then once you establish the patient get admitted, to the floor. Patient has to, you have to take certain precautions. Among them, of course, you have a seizure protocol that to make sure people can seize right after because of the stroke, depending on where the stroke is located. Also, depending on where the stroke is located, that determines some of the sign and symptom that you're going to deal with, okay? Because the different part of the brain control different part of the body. So that goes without saying. You also have to understand if the patient is weak on the right side, it means the stroke occurs on the left side and vice versa, okay? The right side means the stroke occurs on the left side of the brain. If the left side that's weak, it means that the stroke occurs on the right side. Right side means it occurs on the left side of the brain. Left side of the brain, if it occurs there, then the right side would be weak. If it is the left side that weak, then it will occur on the right side. I'm not going to bore you with that because there's a crossover. Now that you've established the patient has a stroke, you have to now try to prevent as much damage as possible acutely. What you do, you make sure the blood pressure is well controlled. You cannot decrease the blood pressure too low when somebody just had a stroke, even though it may be the elevated pressure that caused the problem, unless, of course, the patient can acutely bleed from hypertensive crisis. That can happen. But even then, you have to very carefully, slowly lower the pressure down, because if you do it too fast, you could make the stroke worse, because the patient needs as much perfusion as he or she can get at this juncture to allow oxygen and blood to go through the rest of the brain. You don't want to drop the pressure too low. If the patient's blood sugar is very high, you bring that down, and you have to bring that down quickly, because elevated sugar can create a lot of complications that can make the stroke worse. The patient's cholesterol is very high. You got to bring it down very slowly, so that can also help to make the situation better. If it's not the blood pressure, if it's not the high cholesterol, if it's not the blood sugar, or a combination thereof, then it's got to be some form of inflammatory processes / autoimmune process that has caused the problem. It is up to you then to get yourself a neurologist. One way or the other, you're going to involve a neurologist anyway, because that's the expertise of the neurologist. They're really the one that's in charge of taking care of people with stroke, and they are just fantastic. I use them all the time. They're brilliant people. They're well trained, well experienced. They know exactly. Once I turn the case over to them, they're in charge of the management of the stroke of the patient. I'll then manage the blood pressure. I'll manage the sugar. I'll take care of the cholesterol. I'll take care of all this other stuff. But these folks take care of the stroke. I just leave it to them. Now, you have to understand, if nothing shows up, it wasn't any of these things, then you have to think about the possibility of some vasculitis, meaning inflammation inside vessel, namely the arterial vessel, that can cause the patient to have issues that lead to the stroke. The list of things that can cause somebody to have a stroke go way beyond hypertension, diabetes, and high cholesterol. That is not for me to sit here and try to bore you, to impress you about my knowledge of this stuff. This book that I wrote, The Art and Practice of Modern Clinical Medicine, I wrote this textbook in 2006. In the textbook, I wrote it all by myself from the top of my head. And it's all there. There's a big section that tells you all the things that can cause somebody to have a stroke besides the three well-known factors. Why is that crucial? Well, because we got to manage the patient. If the patient has an inflammatory process that's going on, then you would have done a sedate, you would have done an ANA, which is the basic things you would do. You would have done a rheumatoid factor. You do those three things, and right away, that will raise the red flag. Why should the sedate be elevated if somebody is having an acute bleeding stroke? Shouldn't, because the sedate is a measure of infection and or inflammation. So right away, that would raise the red flag. Why should the rheumatoid factor be elevated if somebody is having a stroke that has nothing to do with inflammatory / autoimmune problem? Right away, that would raise a red flag. Why should nobody having a stroke if the patient is not, the pressure is okay, the sugar is okay, the cholesterol is okay, and then you look at the possibility there may be some underlying abnormalities that was hereditary in nature that caused the patient to be having the problem, that there were abnormalities in the brain that can, for instance, an AVM can cause somebody to bleed inside the brain. AVM is a situation whereby where the artery meets with the vein at that junction right there, automatically there's a weakness. That weakness can easily rupture, cause bleeding to occur. People with AVM of the brain have recurrent seizures all the time. All these things have to be looked at. And or does the patient have some sort of abnormalities in his or her blood that makes the blood thick? Okay? We call those thrombophilia. I discussed in several shows ago, there's about 12 of them. And you have to know this stuff because you're searching all over the place. The patient blood pressure was not an issue. The patient sugar was not an issue. The cholesterol, why is the patient having a stroke? Do they have some hereditary abnormality in the brain that caused them to have that? The rupture a vessel, or you have to look about all this other stuff. These are absolute 2018 modern type medicine. It is not my job. It is not my responsibility if you don't know these things. That's your problem, not my problem. You're taking care of patients. It is your business to be up to date as much as you can be so that you could figure these things out. You can't allow somebody to go and take birth control pill. You can't let somebody take hormone for prostate cancer. You can't allow somebody to take postmenopausal hormone, one kind or another, without first screening them to see if they don't have a thrombophilia. These things are called thrombophilias. For that matter, this may be the first sign that somebody has a cancer because they have a stroke. How do you go from stroke to cancer? Yes, you do. Remember, there's something called Trousseau syndrome. Dr. Trousseau was a French surgeon that lived in the 1800s that first discovered that people who have cancer of the pancreas can in fact develop a clot because of the cancer of the pancreas. And as it turns out, unfortunately, this brilliant surgeon himself wound up dying of his own syndrome, but it didn't die of cancer of the pancreas. Dr. Trousseau died of cancer of the stomach. And he developed Trousseau syndrome. He clot and died because of the clot. There's this confusion. I got into a whole lot of problem at some folks at a hospital here in White Plains that thought that I was demeaning them when they make a statement that was completely false. That is, any cancer can cause Trousseau syndrome, not just cancer of the pancreas. You could have cancer of your big toenail, melanoma of your big toenail. The first presentation could be because you clot. So whenever somebody clot, that clot doesn't have to be in the lower extremities. It doesn't have to be in the brain. It could be in the vessel inside the stomach. It could be in vessel in the lungs. It could be a pulmonary embolism. Every time you see these things, you have a responsibility to look for. Somebody may present with a clot in the arm. So they have a clot in the arm. You're just going to go and treat it? Yes, you're going to treat it, but you also have to look for why. Why do they have the clot? The same way they have the clot in the arm, they could have the clot in the brain and have a stroke. So this is serious, complicated business. Clinical medicine is not a joke. It is serious business. You either know it or you don't know it. If you don't know it, you seek help. When I say these things, folks get angry at me that I'm coming across as knowing it all. No, I don't know it all. I know a whole lot, but I don't know it all. And what I don't know, you don't know. You don't even understand the people who are wasting their time attacking me. I have a process. I don't go to bed at night unless I've learned 12 new things that day that I didn't know before. Let me repeat that, okay? I do not go, and I've been doing that since I was 7 years old, a little boy, after my passing of my mother. I consider it a wasted day if I go to bed at night without learning at least 12 new things I did not know before. If I do, I will get up at 1 o'clock in the morning 2 o'clock, go back and learn this stuff. So therefore, the knowledge base is plentiful. That's me. That's my compulsion. My interest in learning is incredible because that is all I had. Everybody I grew up with had everything in my mind. I had nothing. I didn't have a mother. I didn't have a father. And I came up with this notion, the only way I was going to survive in this complicated world was to have knowledge of stuff, to use my brain power. And I traveled the world to get to this country so that I know this great country can open doors for me, to allow me to go to school, which it turns out that I was correct. No country in this world would have done what this country did for me by allowing me to go to school so that I can remove the shackle of ignorance from my legs. So don't expect me to sit here. So I apologize for folks who had a stethoscope put in the bassinet from the day they were born. Nobody did that for me. I went from the factory to medical school. Okay? So don't expect me to make excuses or to apologize. If you don't know, that's your problem. It ain't my problem. You live in America. This is the new world. Learn stuff. Don't take anything for granted. So therefore, then, you have to look at all these things to find out why somebody have a stroke. You have no idea the incredible diagnoses that you could actually make to save somebody's life and help somebody and the family, for that matter, by looking at one thing. You have to remember something, and I tell the students all the time. You have one chance. You're given one chance to do something, and you better make damn sure you do it right, because you may not get a second chance. That patient walked out of that room and left. There's no way, there's no guarantee she is coming back. And you messed up something, you will never get a chance to fix it. And then over your head is hanging the fact that you did something that was less than optimal. That has nothing to do with perfection. It has to do with thoroughness. And then what most people don't understand, every door has a lock that is compatible to that lock. There's a key to that lock that's compatible to open that lock. The same applies to the field of clinical medicine. There is no diagnosis that doesn't have a key for you to make that diagnosis. It is your job to know those thousands of keys. You can't walk around with this big textbook in your hand. But there are keys to everything. Every single diagnosis has a key. Just like the lock, you have to know what those keys are. You could use one test. You could eliminate 12 different possibilities. If you know what that test is, that's your job. I'm not going to tell you that. I've got to have stuff in my back pocket. I have stuff that I know in the field of clinical medicine I'll be taking to my grave with me. Not because I'm selfish, but because I cannot teach you everything. Then what do I have left? I'll teach you a lot if it is my responsibility to teach you, but don't expect me to teach you everything. So now that you've known the idea, the concept of stroke, let us now talk about the complications. The complications, of course, the patient may not be able to talk. The complication, the patient may not be able to see properly. The complication, the patient may not be able to walk properly. The patient may be able to his or her arm because of weakness. The patient may not be able to have a proper bowel movement. The patient may not be able to urinate properly because the nerve that controls the excretion of urine from the bladder may have been affected by the stroke. So therefore, urinary retention is quite common, with the patient wind up having a Foley catheter being put in his or her bladder in order to allow urine to be excreted, with all the complications thereof. You cannot put a Foley catheter in a female patient without risking an infection 48 to 72 hours. That's exactly correct. You put a Foley catheter in a female patient, 48 to 72 hours later, I shouldn't tell you that, but you're going to get yourself a urinary tract infection. That doesn't mean you don't do it, but there's precaution you have to take when you do that. You can't put a Foley catheter in a man without expecting to have a urinary infection 4 to 5 days later. See stuff you didn't know before, now you're learning. Yet you need the catheter because the urine has to come out. But if you're going to put the catheter in, you have to know the complication of the catheter. Okay, and those are serious complications. People cannot urinate. Oh my God. People cannot have bowel movement. That's a lot. That's a major issue. People cannot speak. People cannot swallow. People cannot see properly. They're staring. They cannot see to the left or to the right, and so on and so forth. They're stumbling all over the place. They're confined to a wheelchair. Therefore, you wind up then, how do you deal with these things? Well, after the stroke has been diagnosed, what type of stroke it is, there's several types. As you know, it could be ischemic, it could be bleeding stroke, could be embolic stroke, and so on and so forth. Then you each one of these things is handled differently, and you diagnose each one of them based on your clinical evaluation, your MRI, your MRA, and your EKG, your 24-hour Holter, your echocardiogram. Because if you have a atrial fibrillation, which is extremely common, very, very common atrial fibrillation. It's very common because of congenital heart disease. It's very common because of ischemic heart disease. It's very common because of hypertensive heart disease. You have to understand you're dealing with a situation here where you have one of every three adults in this country suffer from hypertension. One of every two people of color in this country suffer from hypertension. This is serious business. And all the time that you have hypertension, if it's not being treated properly, all your end organs are being affected. The end organs start from the brain, the eyes, the heart, the kidney. These are the end organs. That's where all these are under constant, daily, intense pressure when your pressure is elevated. And of all the people with blood pressure elevation in this country, less than 50% of them are having the blood pressure controlled properly. Because as we speak to these days, physicians refuse to learn how to treat blood pressure properly. Even though this is the only disease that has an organization that supervises it, they still don't want to do it. I don't know when this problem is ever going to be solved. It turns out that I was shocked to find out the other day when the European Society of Cardiology had the big conference in Europe, that it's the same across the world as well. I really couldn't believe that, because across the rest of the world, people don't have all these, many places they don't have all these fancy machines. They use the clinical bedside manners to treat patients. I was shocked to find out it's the same way. People are resistant to accept who they are, what they are, what is the basis of essential hypertension, which is G-protein coupled receptor kinase, G-protein coupled receptor kinase type 4, a gene that I'm mainly responsible for coming up with the idea. Years ago, before my hair was gray, I came up with that idea that it had to have been a gene that sits somewhere in the human body that allows them to hold on to salt, hold on to water, to prevent folks from Mother Africa, thousands as you go, from all collapse and dying because of the ambient. I just came up with that idea, as I did for several dozen other things that I came up with and published them. And others have, and then sure enough that University of Virginia and Georgetown University believe in that concept, and they did the research. They found that gene, G-protein coupled receptor kinase type 4, in every human being's kidney. The three groups: Caucasian American, Japanese American, and black from Ghana. Those were the three groups that tested. They had access to the kidney specimen. So therefore, it's no longer a mystery what's causing. You can't treat the blood pressure properly if you don't remove the salt from the body and then remove the water as well and then bring it down. If you need to add second medication, yes, you could add a calcium channel blocker, you could add an ARB, and then Caucasian people, you could add an ACE. Why? Because Caucasian people have normal and high ACE. All non-Caucasian people have, I'm talking about renin. The renin leads to the production of the ACE, and all non-Caucasian persons throughout the world have low renin. So therefore the ACE will not work for them. There's not enough renin to block. That's where the problem, the ethnic problem in the treatment of blood pressure, is the secondary medications. The universal medication is a thiazide diuretic that costs about $10 for 30 pills. But I suppose admitting the fact that you need a thiazide to take the water out is admitting that somehow you have a trace of Africa in you, which you do. That's your problem that you don't want to accept that, but you do. You can't be a human being and don't be African to some degree in your DNA. So what's the big deal? I didn't come up with that idea. The people who did the research, so that I think creating this tremendous resistance to accept who they are so that they can be treated properly. It is incredible. People will accept death, will accept the stroke, they'll accept the enlarged heart, they'll accept the kidney that damage, they'll accept the eye developed glaucoma, they'll accept all that rather than accepting the fact that they are who they are, therefore they should be treated properly. This is psychology, and I'm not a psychiatrist nor a psychologist, but it's incredible. Suffice it to say then, all the complications will require the patient go to a rehab center to have physical therapy for the limbs and the arms and so on and so forth. They're going to have voice therapy to help them with their voice if they cannot speak, so on and so forth. And then before you start feeding them, they're going to have evaluation of the swallowing mechanism to make sure they can swallow, because if you don't, and then you feed them, they're going to aspirate and develop aspiration pneumonia, and that could be the end game. So, and there are tons of physical therapists around, excellent professionals, they do a great job. There are a lot of rehab centers all over the place, and the people have to go there. Once the patient leaves the acute hospital, you refer them to either an outpatient rehab or an inpatient rehab to get rehab for the voice, for the limbs, and so on and so forth, so that they can get back to normalcy, so that they can hopefully get a normal life, keeping in mind that once you have one stroke, you have a 56% chance of having a second or a third. It's unfortunate, but that's the statistic. So stroke syndrome is a serious problem. When you have a stroke, you really have to be dealt with permanently in a certain way so that you don't have the second if you can avoid it. It's very important. Your maintenance treatment is crucial. In any event, that's all I have to say about stroke. This is 8 half-hour shows on stroke, and I'm going to stop here. And until I see you again, this is Dr. Alcena saying so long and bye-bye.